And now it's my pleasure to introduce this year's Bortin lecturer, Professor Jeff Szer. Jeff, it really is a pleasure. Jeff's been a longtime friend. Now I have to give the obligatory biography. Jeff is professor and director of the Department of Clinical Hematology and Blood and Marrow Transplantation at the Royal Melbourne Hospital at the University of Melbourne. He's director of the Western and Central Melbourne Integrated Cancer Service. He graduated from Monash University in 1976, completed his training in HemOnc in Melbourne, and was a visiting fellow at the Fred Hutchinson Cancer Research Center in Seattle from 1982 to 1984. He established the first adult BMT center in Melbourne at the Alfred Hospital in 1984 and immediately began reporting data to the IBMTR. His clinical research interests include all aspects of hematology, particularly improving the outcomes of treatment for leukemia, lymphoma, and myeloma. His department has a very strong research program in the treatment and prevention of infections in the immunocompromised host and other aspects of the supportive care of blood and marrow transplant recipients. He also has a particular clinical and research interest in the non-malignant conditions of Gaucher disease and paroxysmal nocturnal hemoglobinuria. Jeff has co-authored more than 220 papers in peer-reviewed journals, and he is an editor-in-chief of the Internal Medicine Journal and on the editorial boards of numerous other international journals. Jeff's CV attests to his commitment to collaborative research, one of the criteria for awarding this lectureship. He serves on the advisory committee of the CIBMTR, and he has served our organization in many, many ways over the years, including being the program chair of this meeting in 2013, quite a challenge for the conference call participation given the time difference in Australia. He chairs the Scientific Advisory Committee and is a member of the National Management Board of the Australian Bone Marrow Donor Registry. He is a member of the Executive Committee of the Australasian Bone Marrow Transplant Recipient Registry, which he co-founded, and is immediate past president of the Bone Marrow Transplant Society of Australia and New Zealand. He is currently the vice chair of the Clinical Working Committee of the World Marrow Donor Association and is a founding representative of the Worldwide Network for Blood and Marrow Transplantation. He also sits on the Gaucher Disease Advisory Committee and chairs the PNH Advisory Committee of the Life-Saving Drugs Program of the Australian Department of Health and Aging. On the personal side, Jeff is known for his eminent common sense, pragmatic approach to problems, and dry sense of humor, as anyone will appreciate who actually read the description of his talk in the program. And I know that we are all looking forward to hearing about the role of Star Trek in the evolution of blood and marrow transplantation. I'm really pleased to invite him to come up and give the 2014 Mortimer M. Bortin Memorial Lecture. Jeff. But first you have to have a picture.
Oh, picture.
Okay. So this reads, presented to Jeffrey Szer in recognition of his many achievements in research and clinical practice that have advanced the field of blood and marrow transplantation. We're this way. You switched.
I'll try not to forget it. Fabulous. Of course, one of the things about the Antipodes is that they don't let us bring in wood, but I'll get it in. So, Mary, thank you very much. I'm extremely honoured by this. It was most unexpected. And I realise I'm standing between you and beer and or dinner, so certainly won't be longer than my allocated time. Many have asked me what Antipodes means. Some have suggested that I use the word antipathy instead, but that's not what I meant. The definition of Antipodes is a point on the Earth to which you would go if you tunnelled directly through the core, which for Australia is somewhere in the North Atlantic, but its general meaning is Australia and New Zealand, at least to the Northern Hemisphere. So that's where I've been isolated for most of the last 6 decades plus. And I wanted to give a view about what we had contributed from down there to the world of bone marrow transplantation, and it's quite a bit, and it's a somewhat individual view of some key studies, key events, key things that have happened that I'm going to put up. And I have been associated with each of them either directly or at least on the periphery. So others have asked me to be quite clear about the difference between Australia and New Zealand. They don't sound like this, they sound completely different, and they don't have these things running around in their hospitals like we do. That's where I work at the moment, and this is hopefully where I'll be working in 2 years' time as a large comprehensive cancer centre goes up across the road from us. So this is the world map as it should look, and the Antipodes are here. You'll notice that we're pink. This is an old-fashioned map where the remnants of the British Empire were always coloured pink. I don't think modern maps do that. For those who are confused about where Australia is, it's not here, and this is for DETA specifically. And this is a real sign that you see certainly in a number of Austrian cities on T-shirts and the like. So my journey started as a medical student in the 1970s, and this was the third edition of the textbook that medical students who had an interest in haematology and wanted to pursue it used in Australia. Carl de Grucci was an eminent Australian haematologist at the time and had a wonderful obituary in Blood in 1975. But so this was the book that I had to teach me about haematology as a medical student. This edition was published in 1970, and there's one little bit in here that I think may be difficult to see. But transfusion of homologous bone marrow has been recently used in the treatment of aplastic anemia. However, because of the immunological problem involved, marrow transfusion as at present performed, has not significantly added to the clinical management of aplastic anemia. Nevertheless, success has been reported with transplants from a twin. Bone marrow transplantation is reviewed elsewhere. So this is the state of play. This is the entire mention of bone marrow transplantation in this textbook at the time, and it's remarkable to me how far we, in fact, have come. So the twin transplants that, in fact, I wasn't aware of this as a medical student, but in fact, Rainer Staub showed me this paper. Barry Firkin, another eminent Australian haematologist, my first clinical teacher as a clinical medical student, and who contributed a vast amount to haematology, mainly in coagulation and platelet function, and introduced ristocetin as a diagnostic agent in platelet disturbance assessment. Among other things, reported the first set of transplants from Australia when he was at the Royal Prince Alfred Hospital in the late 1960s. And this was a hotbed of activity at the end of the 7th decade of the 20th century and showed that persistence was important, that transplantation from a twin could achieve the desired outcome, and used this interesting technique of iron clearance rate to demonstrate that engraftment had occurred, or at least assumed that engraftment had occurred when iron clearance rate decreased, or the rate increased, the time decreased. So this was an early contribution, and of course it wasn't long after this before marrow transplantation became an investigative agent for malignant disease as well, and a couple of years later Mort Bortin had the foresight to set up the IBMTR, which got us all together and brings us to places like Grapevine every year. So Mary wanted to know what Star Trek had to do with bone marrow transplantation and my views from the Antipodes. Well, it's been something that's kept me amused since 1969 when it first aired. In fact, my mother took me to the 40th anniversary convention in Seattle not all that many years ago. So it's pretty scary when my mother is a Trekkie as well. And I must admit, I was afraid to put this in because usually when you mention the word Star Trek together, every woman in the room leaves, and I was quite concerned about that, but I'm pleased some of you have stayed. And I'll show you, I won't spend too much time on it, but I will tell you in what ways I think Star Trek and marrow transplantation and my career have been intertwined. So everything you need to know you can learn from aphorisms in Star Trek. Two at this point, and I'll illustrate why in a moment, seek out new life and civilizations. And when your logic fails, trust a hunch. And so I want to move on to one of the two dons that I've known well through my professional career. This is Don Metcalf. The other, of course, was Don Thomas. And this is not... This publication is actually a book written for the general public, although I'm not quite sure how much of the general public read it, but really is a description of what research was all about at that stage in forging forward in an area that had little support from the institution in which he was. He was in fact isolated in a small laboratory stuck in an animal house off the main campus of the Walter and Eliza Hall Institute, and was prepared to have a 10, 20, 30-year view to get to the point. And it all started in 1970 when Ray Bradley walked across the road from the university with a pretty petri dish full of colonies, or what turned out to be colonies. And this started the search for growth factors. And this book is a beautiful description of what you have to do about your sore back when you're counting colonies every day, which is what he still does about 50 metres away from our ward. So Don Metcalf was very important, and of course after characterising colonies of a variety of kind, he was instrumental in isolating, purifying and characterising both GM-CSF and more importantly perhaps for us GCSF, which subsequently found its way, as we know, into standard clinical practice and really changed the scene for stem cell transplantation for us in ways that we can't even possibly imagine now. So because of the co-location and the close clinical collaboration, we were involved in the earliest clinical trials in man with what became commercialised recombinant human GCSF after the gene was cloned and the product made. The early phase 1 and phase 2 studies were done in a number of Australian centres, but the first experience was in fact in the institution in which I currently work, but didn't then. And the studies were all mono-focused, and this is a demonstration of when you've got a research idea, you've got to push hard. So these studies were set up with a very simple primary endpoint, which was to improve neutrophil recovery after a dose of melphalan. This was a phase 1 study. And then there were a series of other studies, and you're all aware of them, using Filgrastim as supportive care after myelosuppressive chemotherapy, after transplants. Not a single one of them demonstrated a survival benefit. We know that, but we also know that there was one particular use of this agent that has almost certainly produced a survival benefit for us because it enabled autologous stem cell transplantation and subsequently allogeneic transplantation in more patients than would otherwise been able to get them. And the reason for this was a PhD student working at the Ludwig Institute for Cancer Research, another associated institute to the hospital in which I currently work, and Uli Dursen, who's recently emerged internationally for me as a collaborator in some PNH studies, went ahead and did what the sponsor of the trials refused to allow to go ahead, which is he did what they do in those institutions. He started counting colonies in patients who were receiving this new agent in phase 1 studies. And sure enough, dose responsiveness of a variety of different colony types and a time course demonstrated that in fact this agent did mobilise progenitor cells at least, and identified by GM colonies in the peripheral blood, thought to be sufficient to proceed to transplantation. And of course, he made the point that it might be a useful manoeuvre to mobilise stem cells for transplantation to avoid some of the effects of bone marrow harvesting and possibly to reduce the neutropenic and thrombocytopenic period after transplantation. And this is in fact the first patient in the world to be injected with GCSF, and this is Don Metcalf and Richard Fox, who was the chairman of the department at the time and a visionary as far as the clinical development of this was concerned. This fellow, George Morstan, may be known to some people in the room, and I'll refer to him again in a minute or two. And this was one of the most highly cited studies of the time in haematology, which was the demonstration that you could in fact successfully autograft patients with filgrastim mobilised stem cells after high-dose myeloablative chemotherapy and improve improved platelet recovery significantly when compared with bone marrow given alone or bone marrow followed by filgrastim as a post-transplant supportive care phenomenon. So this was the paper. Subsequently, Jason Licklighter, who was a fellow in the department at the time, and collaborators showed that you could duplicate this by improving on what another couple of Australians of import, Vic Toe and Chris Yutner in Adelaide, who did a lot of work in characterising, mobilising and collecting stem cells after chemotherapy, and we did some studies in AML and a number of other disease states to demonstrate proof of principle and export technology to other centres. But this was the first demonstration, and you'll notice there's no mention of CD34 here. We're long before that. This is all colony growth, demonstrating the time course after chemotherapy, which was largely salvage therapy for lymphoma, when given GCSF after that salvage chemotherapy, capable of producing logarithmic increases in detectable colonies in the peripheral blood and the day at which these could be collected and subsequently used for transplantation. So we're in the 90s. Now, the reason I showed you that picture with George Morstan, apart from the fact that it was an important picture, was just to have an aside for a minute of what the growth factor industry was becoming in the early 1990s. And I remember this ASH meeting, which was 1993, very well. And the editor-in-chief of Experimental Hematology wrote a very interesting editorial, which he called Bioeducation. And I'll read some of this as well, because it's quite amusing, and it is of relevance for an Antipodean view. Somewhat embarrassing, really. A funny thing happened to me on the way to the Science at a recent ASH meeting. I ran into a biotech correctional education team in the convention centre. They were all in grey suits, one rather large, overbearing fellow, and two younger colleagues, male and female. The male, younger one was in fact the first author of that seminal autographed paper, who subsequently left academic medicine. They did not look at all pleased. They directed, or more accurately, pushed me into a side conference room in the convention centre. And so it goes on. And then he became witness to the application of advanced biotech statistical approaches, always keeping the mission in mind, increasing the percentage of the populace that can benefit from cytokine exposure. The biotech community has developed the art of subsetting data to the point that they can be sure that every cytokine trial will have a positive outcome. So this is the way it went. And he was corralled, and then he agreed that all results would be positive thereafter. Now, of course, two of those three people were Australians, and it was not a great moment, I think, at that time. And I'm pleased that this was written, because it actually did create some momentum. And I had a chance about 10 years ago to discuss this with the editor who wrote it, and he was still hopping mad about this ages later. So what else did we do with this molecule that we had embarrassed ourselves about? Well, we started to look at normal volunteers, and I don't know whether this was the first normal volunteer study in the world, but it was one of the first uses of the fledgling Australian bone marrow donor registry, which was starting to acquire donors after a community push that was actually begun by the father of a patient of mine who had a syngeneic transplant. And in whom I told him if there was another matched sibling at the time, I may have been happier. Nevertheless, she's done very well. So this was the first normal volunteer study, certainly the only one that Australia participated in, demonstrating the effect of filgrastim in normal volunteers and identifying, this time with CD34 and correlative colony numbers, that we could, again, logarithmically increase the number of colonies and increase CD34s to a level where we thought it would be simple to collect sufficient stem cells for allo transplantation. In fact, the first few patients who developed these white counts of 60, 70 and 80 created some concern, I must say, at the time, and leukapheresis machines were ready on more than one occasion, but fortunately were never required for these people. So this was not a collection study. It was a demonstration that you could mobilise these cells into the peripheral blood, and we all know about the characteristics of the side effects that are seen with this. We also, and this is one of the first studies of what became the bone marrow transplant study group and subsequently was absorbed into the Australasian Leukemia and Lymphoma group, which was an early attempt to do a small randomised study demonstrating potential benefits of the addition of G-mobilised blood cells to bone marrow. And it was an interesting experiment because this group that got both, the donors who got both, in fact were split 50-50 about which of the two procedures they preferred. And this leads on to some other work that I'll talk about in a moment. But it showed what we all now know, that engraftment is quicker when you add peripheral blood stem cells. This was too small to demonstrate any effect on graft versus host disease or outcome, but it was a proof of principle study. So the next, along this line, the next Australian contribution, I think, in the field was one that led to a larger study that followed. And this was a study done in Brisbane by James Mortin, which looked at the effect of stimulating bone marrow with GCSF, with this interesting observation in a single centre study that you could achieve all of the benefits of Filgrastim-mobilised allo blood cells without the downside of an increased risk of graft versus host disease. Now, this study was not huge. You can see 40-odd patients in each arm, a wide variety of conditions, conditioning regimens, matching, etc. But there was no doubt that there was a significantly lower risk of graft versus host disease, both acute and chronic, in the G-stimulated bone marrow with similar engraftment rates. And this, of course, piqued the interest of many and was an ASH presentation. And we were pleased to collaborate with our Canadian colleagues who initiated this large study that was presented at ASH last year, in which an attempt to address this question was repeated in a larger study, a multi-centre study, and with a number of correlative studies that are still undergoing analysis. So this was, and I thank Steve Kuban for allowing me to show a few slides from this excellent presentation. So 223 donor-recipient pairs with a few non-evaluable patients in there across 17 centres. No difference in extensive chronic graft versus host disease or progression-free survival. No difference in overall survival, and no difference. So we're waiting to see what the immunology shows, but it was a very good demonstration of how a collaborative, large, confirmatory trial is always needed before you run away and change practice based on what looks like very convincing clinical data, particularly from a small single-centre study. Now, this slide is meant to remind me to say that I used this expression when CML started to disappear from our diagnostic list in our allograft program. What the hell have they done with our disease by introducing these TKRs? What have they done with lymphomas by introducing rituximab? And in fact, given the way we practice in Australia, I realised that they were us. We had done this to ourselves. But despite this, none of our programs slowed down. In fact, transplantation continued, and plenty of other stuff filled up the gaps that were created by CML, and I think we've seen that globally as well. Now, I just want to talk about a couple of small things that happened along the way, one positive, one negative. A little bit earlier, of course, in the late 1980s, all-trans retinoic acid hit the scene as vitamin therapy for acute promyelocytic leukemia based on some badly interpreted science, but with a fabulous clinical outcome that then created terrific science. This is one of those accidents that I've spoken about in other fora, and I'm happy to expound further if someone wants over a glass of beer later on. But we had this fortunate availability of all-trans retinoic acid in a patient with acute promyelocytic leukemia. Yes, we used to allograft these patients in first remission who had relapsed early after a transplant, and where we were able to re-induce a remission with all-trans retinoic acid as a single agent, which created all sorts of fuss because it was the first time we saw what became known as the ATRA syndrome. It disturbed the last time I ever managed to get to the Australian Open. I remember it very well in the days before mobile phones. But we were able to demonstrate in this small one-patient study that, in fact, the conundrum of how all-trans retinoic acid acted, did it mature the leukemic cells into mature lymphocytes, or did it eliminate the malignant clone, or the malignant clone of cells? We were able to show that it in fact matured those cells into destruction because we had a sex mismatch transplant and were easily able to look at the the chimerism that way in the peripheral blood and the marrow. So this patient became all donor after achievement of remission with all transretinoic acid. So that was a positive contribution, I think, with the help of cytogeneticists and some clinical colleagues. Now, the other thing that we did around this era as a collaborative group, is completely different, it's on a different topic, and hasn't got quite such a happy ending for me, is the fact that we did a number of studies looking at prophylactic intravenous ganciclovir for the prevention of CMV disease, and Kerry Atkinson, who introduced me to the IBMTR the minute I got off the plane from Seattle, and for which I'm very grateful to him, led a couple of studies both within his institution and across the group, which demonstrated that 3 times a week intravenous ganciclovir, in fact, was very successful at the time in the way we were transplanting patients at preventing CMV disease, CMV infection, in the way that we could measure it. Now, those were simpler times, and of course we didn't have the diagnostics we have now. We also didn't do to patients a lot of the things we do to them now. And quite honestly, while we look back on those times longfully, certainly in Australia and certainly in my centre, we have no room to put these patients into an infusion facility 3 times a week for ganciclovir anymore. So when oral ganciclovir was introduced to us by Roche, we thought, hello, here's an opportunity. So the group did a study which actually got an ASH presentation in 2003. And we demonstrated that these were equally effective, and on the day this paper was published, this agent was withdrawn from market because there were better things coming along. So there was a lot of effort there for very little reward, but in fact it was still, I think, a contribution. So, I've got a few minutes I have. So this is Australia. It's a big place. This is the United States upside down and inverted, or it's a contiguous 40 states as well. So it's pretty big. And this is where we are. These are the transplant centres, so adult and paediatric centres in the 5 biggest cities in the country. There are a number of other autografting centres, autografting alone centres around the country, as you'll see in a moment. And of course, and I thank Dave Ritchie, my colleague, for this slide, but this is where nearly everybody lives and does stuff. So there's a vast amount of nothing in there. Total population 23 million. So our population density is largely in that boomeranged area. So because we're so concentrated and isolated, apparently we drink a lot. And we're pretty dark purple here. We're not quite as bad as Russia, but we're next down the line. So this is what they tell me. Mary mentioned that I've been involved with the Australasian Bone Marrow Transplant Recipient Registry, which the initials of which sound very much like the now defunct ABMTR, but not quite. We set this up in 1991, late 1991, as defence against regulation. If we could collect enough data to show our regulators what we were doing and what our outcomes were, we figured that they'd leave us alone. And that's largely what's happened. And in fact, it took nearly 20 years, but we in fact do have some government funding for this now, but it was started started on charitable donations and continued that way until not too many years ago. And so we think that we are probably one of the most complete registries in the world. We have captured about 99.5% of all transplants done in Australia since 1992. That's allogeneic and autologous, and New Zealand since 1998. So we're very proud of this. It's a voluntary thing. There's no payment for participating for the centres, so we've kept the data in simple, but it has given us a backbone to understand what we are doing. And if you can see those numbers, they're the last available figures of how many transplants we do. And the sorts of things we put in our annual report are the breakdown of different types of transplants, and then numerically over the years, we look at age ranges, and so the drift into more elderly patients, particularly in autologous transplantation, has been apparent. We also look at stem cell source and diseases, and again, the absence of CML in this one is quite different to the 1998 report. And we also do 10-year survival analyses for a number of key disease groups, or as requested by the steering committee, just to give us an idea of how we are tracking. It's been a very successful resource for government, and some of the people who have requested data from CIBMTR, some of the same sorts of people have in fact come to us internally from a regulatory purpose. So it's not only been observational, it has been observational largely, but it has been a backbone for some other studies. I'll just highlight two that have recently been done. One was this study which used the survival outcomes of patients in our registry at a 5-year doing a 5-year landmark analysis and looking at mortality data both from reports to the registry and cost correlation with the National Index of Deaths, which is held by the Australian Institute of Health and Welfare. And you can see the sorts of numbers there: 5,500 autologous transplant, nearly 3,000 allogeneic transplants done between 1992 and 2001 to give us a 10-year follow-up. And we're able to demonstrate two things. Firstly, that allogeneic recipients who survive 5 years post-transplant go on to have survival that is slightly better than autologous transplants, and when compared with an age-matched control population within the country is relatively indistinguishable largely. It's a little bit lower. And we were able to demonstrate what happens to these two groups of patients in that second 5-year period, and in the autologous transplant situation you can see deaths equally distributed between relapse and non-relapse factors. These patients are getting older also, but in the allogeneic world, almost all of the failures are related to non-relapse phenomena, and some of them graft versus host disease. You can see a list of them down here. So this was a very important study, I think, and has adds to the weight of evidence that what we're doing is probably a good thing. The other study that has ongoing analysis was a federally funded study of cancer after stem cell therapy, looking at the incidence of second malignancies after hematopoietic stem cell transplants. There are a variety of analyses going on in different subgroups, but there's some emphasis here on melanoma, which is, as you probably know, in the Antipodes, a relatively common solid tumour, largely because of the big hole in the ozone layer that someone put there for us. So I've been involved in a number of these organisations, many of which Mary has mentioned already. They've all been very important. The Bone Marrow Transplant Society was formed relatively recently, some 9 years ago, because we realised as a group within this country, despite the fact that we've been doing all of this, had no political voice at all, and we needed to form a political organisation. And in fact, this society took over the management of the registry, and it's been a very successful partnership. This is the recipient registry that I've just shown you. The Australian Bone Marrow Donor Registry was the first signed partner with the National Marrow Donor Program in the US, and until a few minutes ago, in fact, shared the same software with the NMDP, who were very helpful to us. But I think at one point we were about the third largest registry in the world, not per capita, but in reality, although we've rapidly dropped because we've only got 23.5 million people in the country. The Australasian Leukemia and Lymphoma Group has done a significant number of studies in leukemia and lymphoma, and we're hoping to regenerate that collaborative transplant group that we had in doing prospective studies, and certainly Dave Ritchie, who's here and chairs that subgroup, will be doing a lot of work there. And the World Marrow Donor Association, very important group, and if you don't know anything about the Worldwide Network for Blood and Marrow Transplantation, you should. Its chief instigator and runner is sitting in front of me, but it's a very important organisation for us globally as it attempts to bring transplantation to those parts of the world where it's not easy to get going, and we'll be running a workshop in South Africa later this year with the aim of assisting African countries that don't have transplantation available to them as yet, and it's along the lines that Professor Chandy spoke about, the importance of making what we regard as a very important form of therapy available to everyone who needs it in the world. So, dogged pursuit. It's been dogged pursuit for, I think, all of us along the way. In Australia, it's been isolation but increasing participation, and I've sort of stayed with this organisation because I believe in it. I continue to believe in international collaboration as an important way of moving things forward. So, as I say, it continued, despite some of the other things I do, it does underlie everything I do. Everything is a transplant until proven otherwise. They said it's the hammer and nail story, and has become an important platform for research, and we've heard a lot about that at this meeting. And as some of you will know, it's even advertised in New York subway stations these days. So, back to Star Trek. So I put these last 3 points up with some trepidation, but these are some of the other things you learn from Star Trek. Don't put all your ranking officers in one shuttlecraft, despite the fact that 3 of us from my centre came on the same plane and will go back on the same plane after the meeting. We were heartened at that time by the fact that it was Qantas, which, as you know from Rain Man, never crashes. However, given what happened in Australia to Qantas 2 days ago that some of you may know about, maybe getting home won't be quite as easy as it was getting here. Even in our own world, sometimes we're aliens, and those who have transplant programs within general hospitals only have to go around and ask anyone outside your immediate field what the hell you do, and they'll look at you as if you are an alien because they have no idea. So I think it is true. And, you know, along the foresight that our forebears had, the Mort Bortins, the Don Thomases, the Don Metcalfs, boldly go where no one has gone before. It's very important. This is the think outside the box, and that's underlies all the research that I see presented at this meeting year after year with increasing quantity. So I hope I've shone a bit of light on what happens in the Antipodes and why we do it. And I think I've probably said enough, so I suggest to you all that you live long and prosper. Thank you. This is my team.